last week we went over the conventions. This week we're going over just the outpatient guidelines. And what I'm trying to do is to remind you both and others as they join of the guidelines, how they're going to play a role in your daily job. So there's little things that I want you to remember, because you probably haven't looked at these guidelines in quite a while. But remember that I want you to go back and refresh your mind on all the guidelines. And I'm going to try to do sessions on all the chapter specific. That's what I had intended to do today. And then I thought, that's getting the cart before the horse, as my daddy used to say, because we've got to do the guidelines before we can get into chapter specific. They're important because either they'll get the bill paid or they'll get it rejected. All right, so we're in section 4, diagnostic coding and reporting guidelines for outpatient services. So when you pull up your guidelines and find a code, or wherever, if you go to the CMS website, wherever you get them, this is going to be section 4. This is what you're going to focus on in your work, because you two are credentialed outpatient coders. You have studied and passed the exam, and what you're proficient in is outpatient. Okay. The first guideline when we go into this section is the selection of first listed condition. Now, I've summarized it here for you. The guideline itself says in the outpatient setting, the term first listed is used instead of principal. The reason I wanted to bring that up is as you move into your job, you may hear the terms principal, but that's more applicable to an inpatient coder. In the outpatient world, it's first listed. It's or primary diagnosis. You'll hear that a lot too. You won't hear principal. That's focused on the inpatient coding. But here's what we're told for the selection of first listed diagnosis. When we're trying to determine what our first listed is, the general and disease-specific guidelines take precedence over the outpatient guidelines. So you need to remember that, because when we get into chapter specific, if there is a conflict of interest in what the chapter specific is saying and what chapter 4 for the outpatient, we're clearly told at the very beginning of our guidelines that the disease specific, which is our chapter specific, take precedence over these outpatient guidelines. So you want to remember that. And a lot of that applies when you're coding neoplasms and your obstetrics, but those are chapter specific, okay? The first listed condition here that's discussed in the guideline is our outpatient surgery. When a patient comes in for outpatient surgery, which is also called same-day surgery, which is what you all have been coding in the virtual internship, basically, is outpatient surgery. You're going to code the reason for the surgery as your first listed. Why did the patient come in for the surgery? Even if the surgery is not performed because of a contraindication. And what that's telling us is if the patient comes in for tonsillectomy and the blood pressure elevates and they stop the procedure, you're still going to code that diagnosis that brought them in for that tonsillectomy. The example that I've used here, code the reason for surgery, The patient is admitted to outpatient surgery for the repair of an umbilical hernia. Your first listed diagnosis is going to be your umbilical hernia. Okay, so what happens if a patient is admitted for observation? It tells us that when a patient is admitted for observation for a medical condition, we're going to assign a code for that medical condition. What about when a patient presents for outpatient surgery and develops complication requiring admission to observation? You're still going to code that reason for surgery as your first listed. Then you will assign codes for your complication. And you could very well come across that in your coding on your words. The example that I use for medical observation, code the medical condition. The diagnosis is the reason, such as the chest pain, rule out MI. And then I used an example here of a patient admitted for outpatient surgery and develops complication requiring admission to observation. The reason for surgery is the first reported diagnosis, which is what I just read from your guideline. Don't let this one trip you up. Make sure that you make notes because you don't actually have a paper copy, but you can easily make notes in a notebook, whatever form you use to help you remember. But let one section be the conventions that we discussed last week. Make notes on those. The second section, let that be these chapter 4 guidelines. Another section, let that be the chapter specific as we get into that. And then in October, when the new guidelines come out, you'll want to go in on that same page of your conventions or your guidelines and make notes for the new fiscal year. It's just a really good way to get organized with this and to help you. Because when you're in your job and you're trying to remember something and you know you wrote it down, if you break it up into categories, I think that will help you all. The next guideline that we're going to look at is our ICD-10 CM code for the diagnosis, condition, problem, or other reason for encounter and visit. Right? The guideline tells us to list first our ICD-10 CM code for the diagnosis, condition, problem, or other reason for the encounter that is documented. The guideline says shown. I use the word documented in the medical record to be the reason that the services are being provided. Then you can list your additional diagnoses that we also refer to them as secondaries. So I kind of broke it out here. This is what, if you're making notes, the first code represents the reason for the visit. Then you can code additional coexisting conditions. The example, patient presents to the office with acute abdominal pain. Workup includes ordering tests and x-rays. The patient is also a type 2 diabetic, and they did a glucose check in the office. It was normal, but they still checked it. So the physician documents acute abdominal pain and possible cholecystitis. Well, we can't code possible, right? So we're going to code the acute abdominal pain. Do we code the diabetes? Yes, we would. That's correct. This patient has diabetes. They did a glucose check in the office. Absolutely, we're going to assign that code as an additional diagnosis. Our next guideline, which we just kind of used in the previous example, make note of this. Do not forget this. Do not code diagnoses that are documented as probable, suspected, questionable, rule out. You'll see a lot of rule out. That is a very routine way of putting a diagnosis down. Rule out, ruled out, also compatible with, consistent with, or working diagnosis, or other similar terms. Basically, if it's not confirmed, you're not going to code it. And the physician that you work for may have a totally different way of saying that he don't know. He has not confirmed a diagnosis yet. So there's still workup to be done. You're going to code the condition to the highest degree of certainty. So even if that patient is very sick, they've got that abdominal pain, and he's ruling out cholecystitis, he's ruling out pancreatitis. No matter what he's trying to rule out, that is a severe diagnosis. You cannot assign that unless it's confirmed. You've got to go with the abdominal pain. In the guidelines, it tells us that this is different, and basically it's different for acute care if you were an inpatient coder. The example that I used here is the provider documents probably UTI. He starts the patient on antibiotics before testing the urinalysis or doing a culture. The first listed diagnosis will be the signs and symptoms that the patient presented with, which include but may not be limited to burning with urination, frequency in urination, blood in the urine, back pain. So those may be symptoms that you have on your chart, even though he's treating for UTI, he only documents probable. So you still can't go with it, even though there's an antibiotic ordered. You're going to get that if you're doing an E&M, you're going to get that prescription management, but your diagnosis is not going to be UTI. The next one is chronic diseases. Chronic diseases treated on an ongoing basis may be coded and reported as many times as the patient receives treatment and care for the condition. Here's a very important note. Chronic diseases and/or conditions are only reported if they have an impact on the care being provided during that visit. All right, so let's look at an example. The patient presents with upper respiratory symptoms for evaluation. The provider noted and documented that the patient has a history of hypertension. The patient is no longer taking medications for hypertension, but it is controlled with dieting and recent weight loss. The patient's diagnosed with URI, upper respiratory infection, and the patient's given antibiotics. Are we going to code the hypertension? You can see the answer on the screen. You know that you're going to code it, even though he's no longer taking medication for the hypertension. It's still part of the chart that it's a diagnosis, and the way of control is no longer by medication. It's by the patient himself actually working on getting his blood pressure down through his diet and exercise. The other thing that I brought up that I put as a rationale is there are certain over-the-counter medicines that elevate our blood pressure. So the fact that we have high blood pressure, that plays an important role because that determines sometimes how the physician treats us in the medications that he gives us or recommends. You know, they will recommend over-the-counter medicine, and there are some that they will not recommend because of the fact the patient has hypertension. Diabetes is another one. Chronic diseases trips us up a lot. How do we know what to code and when to code? Sometimes it's just a matter of policy for that specific physician. If you are focusing on the guidelines, which is what you have to do until a physician says we don't code certain diagnoses, then you're going to code based on these guidelines. This is what supports you as a coder for being accurate and complete. There are certain physicians that will tell you, I do not do history codes. So be prepared for certain policies and procedures that will affect different institutions, facilities for outpatient coding, physician for outpatient coding. I used another example here that I wanted us to look at. This is a 60-year-old female. She presents, she has a subcutaneous abscess. Her last visit was 1 week ago. Her symptoms include pain, swelling, tenderness, and drainage. The abscess is located in the left buttocks, and the patient's pain is described as sharp. She had a previous abscess that was treated with antibiotics. They will try those antibiotics again. However, if those antibiotics don't improve this abscess, the patient's going to need an IND. Patient has history of diabetes. And the physicians document just this way. Okay, this is taken from exactly what you're going to see in a physician. He says history of diabetes. All right, so the patient checks his blood pressure regularly. He's on Toprol for his blood pressure. Additional documentation says blood sugars are stable and controlled with metformin. No episodes of hypoglycemia, no side effects of meds, and he's compliant with his treatment. In the assessment piece on the physician form, the physician documents buttock abscess, diabetes mellitus well controlled, hypertension well controlled. His plan is to try antibiotics and then the IND if that doesn't work. Are we going to code the diabetes? Yes. Yes. What I want you to see here is that history of us. Don't let that trip you up. Because this is exactly how they word it a lot of times. That just what that physician is thinking is it is a condition that the patients had for a length of time. It's not that it's history of and it's resolved. And we know that because this patient's on metformin. If that patient didn't have diabetes, she wouldn't be on metformin. And if you have diabetes, it's not going to go away. So this right here, you're going to see a lot. And that is just the physician's thoughts. Hey, Annie Mae has had diabetes for years, so she has a history. That's their thought process. They are not coders. Blessing, do you have a question?
Yes, yes, Faye.
Okay.
Let me ask concerning the metformin. At this point, we can code for the metformin. That's putting Z90, Z79.8 something. Use of oral hypoglycemia drugs.
That is correct.
Okay.
Yes.
Thank you.
You're welcome, and thank you for the question. Yes, and when you go to diabetes, remember, do not assign a code without going into the tabular, because that is where your includes, your excludes, all your important informational notes are located. So when you go to code that diabetes, then you're going to have also code. So that's a good question. Thank you, Blessing, for bringing that up. So what I wanted you to see here is that you're going to see this. You're going to see history of. You may see history of hypertension. And that one may throw you for a loop because that may be that the patient had an elevated blood pressure in the patient's past, but it's fine now. And there's no treatment. There's no other documentation. So let's just use that as an example. Let's say that this did say hypertension. Disregard this note right here. That's all it says, hypertension. And there's nothing here. Take this out. Whoops. Take this out. Take that sentence out. And all you have in your chart is a history of hypertension. Patient is not on any medication. There's nothing being done. Would you code it?
No.
Thank you. That's correct. Because it's not being treated. If we go back, chronic diseases treated on an ongoing basis may be coded and reported as many times as the patient receives treatment and care. So this is a guideline that you really want to make note of in your notebooks. All right, let's move to code all documented conditions that coexist. These are sounding kind of like each other, don't they? I mean, it seems like a lot of diagnoses are running together, not diagnoses, guidelines. But there is a reason for each one of them because they specifically address a different condition. Blessing, do you have a question?
Yes,
I see
Faye.
that.
Sorry for taking us back. So for that particular example, do we have to put the hypertension there? The one we just
In
left?
this example, yes,
Yes.
I'm back on
Yes.
that. Yes, yes. Okay. Because, and you're
Okay.
going to give it points. You're going to give it points in your NEM for a chronic condition because the patient is on Toprol. He's checking his blood pressure regularly. So this patient's just here because he has an abscess. But all these others, we know that diabetes affects skin conditions. So we know we're coding that. We just discussed that. The hypertension, the physician documented that he's on Toprol. He checks his blood pressure regularly, and he put it in the assessment. Yes, we would code that. All right, let's look at all documented conditions that coexist at the time of the visit that require or affect patient care, treatment, or management. Do not code conditions that were previously treated and no longer exist. There are history codes, however, and that's in your Z category codes that may be used as secondary codes if the condition has an impact on the current care. Remember, more is not always better. And the reason that more is not always better is when you're coding for that physician, if you code diagnoses that should not be coded to get them into a higher level for their evaluation and management, when that physician, if that specific bill was to be audited and the chart audited along with it, and you incorrectly coded, that is called upcoding. Okay, so that's a term that you'll hear, upcoding and downcoding. Upcoding means that the coder coded diagnoses that were not appropriate for the visit. Is important, is more is not always better for diagnosis coding. Capturing and reporting those diagnoses that should not be coded based on your guidelines is potentially upcoding. Because if you code diagnoses, let's say that you code a pneumonia, you code a UTI inappropriately because it's documented as probable, and you code it as definitive. You put that pneumonia code or you put that UTI code. The insurance pays the provider an amount based on the conditions, the codes that you report. If the payer comes back in and does an audit for any reason, and audits are typical because everyone wants to make sure that the providers, the hospitals, the clinics, the outpatient surgery centers, that they're all reporting appropriately. So there are audits that are routine, quarterly, semi-annually, annually. So it's not uncommon to be audited anymore. If they audit that chart that you put the UTI on, and that patient actually did not have a confirmed UTI, only possible, and it affected the payment, such as in the E&M level, then you will be documented as upcoding that chart. So you want to be very careful that you follow these guidelines, because these guidelines affect the reimbursement that the physicians and facilities, whether they're outpatient or inpatient, Coding drives the reimbursement. These guidelines are put in place so that we do not code inappropriately. There will always be times when you have questions and concerns. Should I code or should I not? Never hesitate to reach out to someone else. You'll have a coding manager, you'll have someone. You're not going to be put into a job and be on your own. There is always a support person. Never hesitate to ask questions. Let's look at an example here. So let's go to the example. A patient presents with difficulty urinating and is diagnosed with BPH. That's benign prostatic hypertrophy. The provider documents in the record that there is a family history of ovarian cancer in the mother and prostate cancer in the father. What diagnosis should be coded? Right, so here I've already put our answer here. BPH is reported along with a Z code for the past history of prostate cancer in the father. No code is going to be reported for the mother's ovarian cancer because this is a male patient, and the fact that the mother had ovarian cancer is not significant for his condition. Does that make sense?
Yes, it does.
All right. Patients receiving diagnostic services only. This is a long guideline. There's a lot of information in here. I've got examples on the next slide. But what it's saying here is that if a patient's coming in for diagnostic services only, then you're going to sequence the condition or the reason for the encounter. You can code for your chronic conditions, but the reason for the encounter. If a patient's coming in for routine lab and radiology, then you want to assign the code Z01.89. And then it tells, I put this in here, so make a note because I'm not going to try to pull it up on my screen. Unfortunately, my internet might go out, but I want you to look at the Z01 category sometime after our Zoom meeting today. I want you to see the instructional notes there. And remember, if you follow the instructional notes, it typically tells you the specific diagnoses, what to include in the diagnosis coding that you are doing. If a routine test is being performed during the same encounter, test to evaluate a sign or a symptom that the patient's having, you can assign the Z code and the code describing the reason for the non-routine test. So for example, if that patient comes in for a chest x-ray and there's no documented reason, and then we have a urinalysis testing because of cystitis, or I'm sorry, urinary tract infection, let's use that, then we can code the urinary tract infection because that is a documented diagnosis. So you've got the patient coming in for two different reasons, and one of those you do not know the diagnosis, so you're going to assign your Z code. And for the other one, you do have a diagnosis, you would assign your diagnosis. Here's something to pay attention to. When you're coding in the outpatient world and the x-ray is available, the lab results are available, and they got documented results signed by the provider or the interpreter, such as the radiologist, you can code from that radiologist report. So if a patient comes in, let's say we have a 9-year-old that comes in with fell off the bicycle, possible broke arm, by the time you code that chart, you have an x-ray that shows you fracture of left ulna. You can code that. You don't have to code arm pain because you have a definitive diagnosis. You would not code those signs and symptoms. Here's some examples that I just pulled together last night for diagnostic services only. If a patient comes in and they're just doing a blood type because they're having surgery tomorrow, this is in your Z codes, Z01.83. It's an encounter for blood typing. And remember, in your alphabetic index, encounter is your main term. What about the patient that's having an MRI of the head to monitor the progression of the brain tumor? Well, we have a definitive diagnosis. So we don't have to do an MRI, we don't have to do an encounter for an MRI radiological exam. We can actually code D49.6 brain tumor. And then we have the patient that comes in with no symptoms with to have a CBC. That's your Z01.89 laboratory exam without any signs or symptoms. If there were signs and symptoms, this code would not be appropriate and you would assign, and I did not pull the code, but you would go and look for laboratory exam, your analysis, and then you would code your secondary, your additional diagnoses as your signs and symptoms. This is for the patient receiving therapeutic services. So what this is telling us that the patients that come in for the therapeutic services, you're going to sequence first the diagnosis or the problem or the reason for the encounter. And again, these chronic conditions can be sequenced as additional diagnoses, but keep in mind, only if it meets the guideline for chronic conditions that we just went over. The only exception to this rule for therapeutic services is when the primary reason is for chemo and radiation. And that's your chapter specific guidelines. Because chemo and radiation, there is a Z code for chemo and there is a Z code for radiation. So those codes would be listed first. Remember, chapter specific guidelines take precedence over section 4 outpatient guidelines. An example here, the patient had a phlebotomy for polycythemia vera. You're going to code the diagnosis because we have that confirmed. Okay.
Yes, I have a question.
Yes.
Yeah, concerning where you have the symptoms code, the codes, the R codes.
Yes.
So does it mean that symptoms are only placed on the R codes? We can't find symptom codes outside the R codes.
We would code symptoms if we don't have a definitive diagnosis. And those symptoms are in our R code categories.
Okay, so that means we can't find any symptoms outside the R code.
Can you give me an example, Bledson? Can you think of something?
Like just think of maybe a symptom being outside an R code, maybe like in A code or B codes.
Okay.
So all the symptoms are placed under R codes. We can't find other symptoms outside there.
Okay. So if you have, let's say you have sepsis, because that's like an A code. And with sepsis comes a lot of symptoms. You're not going to code those symptoms.
Okay.
Does that make sense? Is that what you're asking me?
No, I know that symptoms codes are in the R codes.
Yes.
Like R is for symptoms. So I was asking, like, is it possible to have other symptoms code outside R codes?
Symptoms outside of our codes.
Yes.
Okay. Okay. You could have symptoms outside of our codes. So you want to be careful that you identify that as a symptom. I know that in the N category in urinary, there are some specific diagnoses that fall into the N chapter, I believe, that you If they are a symptom of a specific diagnosis that's documented, then you're not going to assign those unless at your specific diagnosis, there are instructional notes that tell you to code like stress incontinence, such as those. So you may have instructional notes that tell you to code symptoms, and those symptoms are not in the R category. So yes, there may be symptoms in other categories.
Okay, thank you.
You're welcome. Okay, this is for pre-op evaluations. A lot of times a patient comes in, they're having a surgery by one physician, but their primary physician needs to do a pre-op evaluation to approve their surgery. So the guideline tells us for patients receiving those pre-op evaluations, you're going to sequence first a code from subcategory Z01.81. This is an encounter for pre-procedural examinations. So if it's a pre-op consult, you're going to have to assign Z01.81. Then, as additional diagnoses, you want to assign a code for the condition that describes the reason for surgery. So if this patient's having cardiac cath, that's going to be an additional diagnosis, the diagnosis such as chest pain, because the cardiac cath is going to be an evaluation of seeing the determination if there's any blockages or anything. So that patient's having chest pain, they're going to have a cardiac cath, and he just wants his primary physician to do an evaluation to clear him for surgery. All right. So the surgeon will want and then which is what I've just described. So if you have a pre-op evaluation, and it's going to document in the chart pre-op evaluation Z01.81. This is, and as it told you here, this is subcategory Z01.81. That lets you know that that's not a complete code when you see the word subcategory. So if I come over here, I see Z01.810 for pre-op cardiovascular exam. And then the 811 would be a pre-op respiratory. All right, so Lucy is an 8-year-old who was brought into Dr. Adams' office for a pre-procedural consultation for a mass on her left lung. Dr. Adam reviews the patient's x-rays and MRI, which were taken the previous week and sent from Dr. Goodman, which is Lucy's pediatrician. So without looking in the code book, what Z code, the question is, what Z code would you report for the pre-procedural consultation? Well, we have it here because I provided it in an example, the Z01.811. So that's going to be a pre-op consultation, left lung. Lung is in our respiratory system, and that's how we determine the specific examination. So Z01.811 is going to be our Z code. And then we're going to report a diagnosis code for the lung mass. And then the question is, which one's first? Well, we know that Z01 is going to be our first listed diagnosis. So you want to look in your code book at Z01, not code book, I'm sorry, in your find a code, Z01, and you want to go ahead and just look through that. Just get familiar with what all is in that subcategory. Because this patient has a lung mass. She's 8 years old, she has a lung mass. So this is a respiratory. pre-op. For the cardiac cath, it would have been 810. So it depends on what the type of surgery being performed is going to drive your code for your pre-op evaluation exam. All right, ambulatory surgery. Now, this is what you've been working in the virtual internship. So, but we have a guideline, and what it tells us is you're going to code the diagnosis for which the surgery was performed. If the post-op diagnosis is different from the pre-op at the time, then you're going to select the post-op since it's more definitive. The examples here, pre and post-op diagnosis are the same. Patient had an EGD for upper GI bleeding. The post-op is upper GI bleeding, etiology undetermined. The physician could not determine the reason for the bleeding. So your GI bleeding is going to be your first listed diagnosis. And what about the patient that has the EGD for GI bleeding and the physician determines that the bleeding is due to a gastric ulcer? There is a code for a combination gastric ulcer with hemorrhage. That's going to be what you assign as your first listed diagnosis. This one you pretty much, you've worked in the virtual internship, you're familiar with what to assign first. It's just something to remember when you're out there coding for your physicians, that you want to make sure that you pick up the post-op and not the pre-op diagnosis. The last one that's in the guidelines is the subcategories for general medical exams. Those are in your Z00 categories. If that medical exam results in an abnormal finding, then the code for the medical exam with abnormal finding is listed first. And it defines that an exam with abnormal finding refers to a condition that is newly identified or a change in maybe a chronic condition that the physician determines during a routine physical exam. You're going to also assign a secondary code for the abnormal finding. But when this patient is coming in for a medical exam, that Z00 category is where you want to look. So you want to look in your index for encounters. As a little bit of homework to do as well, pull up Find a Code. In the index search, look at the word encounter. And I want you to scroll and look at each of those. I want you to know what's in that category. That there is so much there, and it's important that you're familiar. And that term encounter a lot of times throws us off. We don't always look for that. We know that the patient's here for a medical exam, but we don't think about encounter because your physician that you're coding for is not going to say encounter. He's not going to document that. You just know he's here for a medical exam. And that's the end of the outpatient guidelines.